Swastiastu. Greetings to facilitator and evaluator. We are from small group discussion B3, and we will explain to you about acute hematogenous osteomyelitis. These are our members that participated in this student project. And then let's start with introduction.
Hello, Dr. and my friends. My name is Dewa from Prema Shanti, and the last 3 digits of my student ID number is 004. So in this occasion, I would like to tell you about Chapter 1 Introduction. Next. First is background information. Osteomyelitis is a bone infection that usually caused by the Staphylococcus bacteria. Osteomyelitis is a rare disease, but it needs to be treated immediately because it can cause a number of serious complications. One type of osteomyelitis disease is acute hematogenous osteomyelitis. Acute hematogenous osteomyelitis is an infection that usually affects growing bone, especially the most vascularized bone area with symptoms lasting less than 2 weeks. Due to the increasing number of osteomyelitis cases in the last decade and as an effort to fulfill the assignment, our group discussion interested in making a student project with the topic of acute hematogenous osteomyelitis. And the problem formulation of our student project are: what are the definition and epidemiology of acute hematogenous osteomyelitis? What is the pathogenesis of acute hematogenous osteomyelitis? What is microbiology, etiology of acute hematogenous osteomyelitis? What are clinical manifestation of acute hematogenous osteomyelitis? How to diagnose acute hematogenous osteomyelitis? What are differential diagnosis of acute hematogenous osteomyelitis? How to manage acute hematogenous osteomyelitis? What are the prognosis and complication of acute hematogenous osteomyelitis?
Okay, my name is Bagus from Satia Saputra, and I will continue the presentation. So the purpose of writing the student project is first one, to know the definition and epidemiology of acute hematogenous osteomyelitis. Second one, to understand the pathogenesis. The third one, knowing the etiology. The fourth one, knowing the clinical manifestation. The fifth one, understanding and able to diagnose. The sixth one, knowing differential diagnosis. Seventh one, to understand the management. And last one is knowing the prognosis and complication of acute hematogenous osteomyelitis. The benefit of writing this student project is to enhance the knowledge and understanding of acute hematogenous osteomyelitis. This content intends to amplify the understanding of the definition, epidemiology, classification, pathophysiology, etiology, risk factors, sign and symptom, diagnosis, differential diagnosis, treatment, and the prevention. In addition, the student project is also expected to be a reference for other research related to acute hematogenous osteomyelitis.
Hello, my name is Ketut Febrianti Puspa Dewi, with the last 3 digits of my student ID number is 041. So I will continue the presentation with the chapter 2, which is the discussion. So we will start with definition and epidemiology. For the definition, osteomyelitis is an infection that involving the bone marrow, periosteum, and also surrounding of the soft tissue that lead to sclerosing and destruction of the bone. From various types of osteomyelitis, the most frequent form of the disease in pediatric is acute hematogenous osteomyelitis. For the epidemiology, this disease most commonly seen in school-age children, with the range of worldwide incidence are between 1 to 1,000 to 1 to 20,000, with half of the cases are occur in children younger than 5 years of the age. That's all for me. My friend will continue the next part. Thank you.
Okay, my name is Raharja, with last 3 digits of student ID number is 136, and I will continue to the pathogenesis. The pathogenesis of AHO is not completely obvious. Nowadays, transition bacteremia combined with characteristic of the growing bones are believed to be the mechanism of AHO. Transition bacteremia can result from otitis media, pharyngitis, and activities of daily living such as brushing teeth. Osteomyelitis begins to develop in the metaphyseal area of long bones. The blood vessels in the growing metaphyseal area form tight hairpin loops that creates an area of relative vascular stasis and rich slow blood flow. This metaphyseal area is susceptible to microthrombi and microhematomes with relatively minor blunt trauma, which is sites of the infections develops. The organism will replicate and proliferate to form abscess that can penetrate the cortex, resulting in superosteal abscess and periosteal elevation. Okay, that's all about the pathogenesis, and the next slide will be continued by my friend. Thank you.
Hello, my name is Angelique and the last 3 digits of my student ID number is 068. Now I would like to explain about the etiology of acute hematogenous osteomyelitis. AHO has a bacterial etiology that changes with age. The most prevalent cause of acute hematogenous osteomyelitis in both adults and children is Staphylococcus aureus. Staphylococcus aureus is the most frequent species of Staphylococcus we can find on the skin. Other common organisms causing AHO include Group A Streptococcus, gas, Streptococcus pyogenes. It is the second most prevalent identified causative pathogen in AHO in the group of older children. And then we have methicillin resistant S. aureus MRSA. It is increasingly being identified from osteomyelitis patients. Because of its enhanced virulence, it is a more dangerous and worrisome bacteria. And then we have group B Streptococcus, GAB, Streptococcus agaricti. It is a well-known cause of AHO in newborns and young infants. And then Kinia with this pathogen is most usually linked with septic arthritis, but it has also been found in osteomyelitis and may be found in children aged 6 months to 4 years old. Gram-negative rogue salmonella must also be evaluated in AHO, especially in premature infants. Salmonella, in addition to S. aureus, commonly cause osteoarticular infections in children with sickle cell anemia, complicating its disease, frequently seen in immunocompromised patients. And then the last, we have Streptococcus pneumonia and Haemophilus influenza type B, HIV. Children who have not been vaccinated or who have only been partially immunized against Streptococcus pneumonia and Haemophilus influenza type B are more likely to acquire invasive illnesses including osteomyelitis. However, these bacterial infections are now rare because of effective vaccinations regimens. I think that's all from me. The next part will be explained by my friend. Thank you.
Hello, my name is Sophie Paramittha with my last 3-digit ID number 156, and I will be mentioning the clinical manifestation of acute hematogenous osteomyelitis. Keep in mind that it may vary based on the age and disease type. So the most common features of acute hematogenous osteomyelitis are fever, localized pain or symptoms, limited range of motion, and reduced weight bearing. And also there are several other features such as tachycardia and several limbs. That is all from me. Next will be delivered by my friends. Thank you.
Hello everyone, my name is Agustin Rahtatariteornam with the student number 20025111215 here to continue the presentation with 2.5 diagnosis. So acute hematogenous osteomyelitis is diagnosed through a series of combinations of tests which involve factoring in physical examination as well as the history of the patient, a series of imaging tests, separation of the microorganism taken from the area along the bone or joint or blood, and of course laboratory examinations. So there are 4 things to point out in regards of the diagnosis, which are inflammatory markers, imaging techniques, culture, and polymerase chain reaction or PCR. So starting off with the first point, the inflammatory markers, there are 2 non-specific markers of inflammation, which are CRP or C-reactive protein and erythrocyte sedimentation rate, or better known as ESR. Next up is imaging techniques. So radiography and ultrasound technology could also be used to exclude other causes that may trigger AHO. Next up is culture. So bone biopsy and joint fluid samples is highly crucial aspects that needs to be have on hand before the administration of antibiotics. And last one is polymerase chain reaction. So PCR may enhance the finding of KJ, but is quite expensive and not yet readily available. So that's over me. Next.
Okay, hello everyone. My name is Evangelina Vincent Oetami with 3-digit last student ID number 170. On this occasion, I will going to continue explain about the differential diagnosis of acute hematogenous osteomyelitis, or we can call AHO. So AHO has a broad differential diagnosis based on evaluation of patient with a suspected bone infection. This differential includes septic arthritis, cellulitis, pyomyositis, spondylodiscitis, Gaucher disease, thrombophlebitis, patient with sickle cell disease, bone infection, trauma, and the last one is malignancy. Because of that, to establish the diagnosis, patient will require to do some examination such as laboratory and imaging examination. Okay, that's all for the differential diagnosis. The next point will be explained further by my friend. Thank you.
Hey everyone, thank you for the chance. My name is Trifena Lisanias. With the last 3 digit of student number is 119. Today I will explain to you about management of acute hematogenous osteomyelitis in ophthalmology side. Typically, intravenous antibiotics are given to the patients with acute hematogenous osteomyelitis or suspected acute hematogenous osteomyelitis. Antistaphylococcal penicillins or first-generation cephalosporins are suggested at low prevalence MRSA or methicillin-resistant Staphylococcus aureus regions. For MRSA, vancomycin is recommended to be consumed at doses of 60 to 80 milligram per kilogram per day every 6 hours for children aged 3 months until 12 years. That's for me. The presentation will be continued by my friend Anggi. Thank you.
Hello, my name is Anggi Amanda Triana Devy with last 3 digit of student ID number R088. I will continue the explanation about the management of acute hematogenous osteomyelitis. Besides MRSA, there are also drugs for the methicillin susceptible S. aureus or MSSA infection, which is more benign than the MRSA infection. The recommended treatment for MSSA is penicillin, oxacillin, and oral anti-staphylococcal beta-lactam, such as diclofenac and cephalexin. Surgical procedure is needed when there is abscess from the subperiosteal space, soft tissue, or the metaphysis. However, this procedure can be avoided if the lesion is early and the abscess already decompressed by the needle aspiration. Antibiotic therapy alone will be enough for patients with age 1 year above and the symptoms duration less than 48 hours. Okay, that's all from me. Thank you.
Good morning, good afternoon, and good evening, doctor. My name is Putri Yudhistira with last student digit ID number is 098. I will continue the presentation about prognosis and complication. So, acute hematogenous osteomyelitis or AHO has many complications, especially if it's caused by methicillin-resistant Staphylococcus aureus or MRSA. The complication can be subperiosteal and intraosseous abscess, deep vein thrombosis, multi-organ failure, etc. Staphylococcus aureus virulence factor, named pentanvalentine leukocidin, can cause leukocyte destruction and also tissue necrosis. Besides of that, bone growth disruption and angular deformity can also occur in bad condition. But however, AHO in children is still can be cured. The key is also early diagnosis and proper treatment.
Greetings, my name is Raharja Now I'm going to explain about the conclusion. The first one is osteomyelitis is a bone infection that usually caused by the Staphylococcus bacteria. Second, osteomyelitis is a rare disease, but it needs to be treated immediately because it can cause a number of serious complications. Third, the clinical manifestation of AHO may be vary based on the age and disease type. The most common features of AHO are fever, localized pain or symptoms, limited range of motion, and reduced weight bearing. The fourth, children with suspected acute hematogenous osteomyelitis or AHO should be checked the patient's hemodynamic state early in the evaluation. The last one, typically intravenous antibiotics are given to patients with AHO or suspected AHO, and AHO also requires treatment such as penicillin, oxacillin, and oral anti-staphylococcal beta-lactam such as diclofenac and cephalexin. That's all from me. Thank you.